Good afternoon, everyone. Welcome back to another Facebook Live session on cancer care by American Oncology Institute. And today we have with us Professor Dr. Major Shibashish Bhattacharyya to talk on lung cancer. Dr. Shibashish is currently working as a senior consultant, Department of Medical Oncology at American Oncology Institute, Imphal unit. And he has over 25 years of experience in cancer patient care. And Dr. Shibashish is a native of West Bengal, and he has completed his MBBS from Medical College, Kolkata in 1990, did his MD in medicine from Delhi University in 2002, and DM in medical oncology from AIMS Hospital, New Delhi in 2008. And he has also served in the Army Medical Corps as a major from 1993 to 1998. Hello and welcome,
Hello.
sir. So,
Namaskar.
to proceed with today's session, first and foremost, what is lung cancer and what are the causes of lung cancer?
Lung cancer is actually a irregular and uncontrolled growth, like the definition of cancer of the lung tissue. Among the different lung tissue, mostly the cells lining the alveolus or bronchus, these are the areas from where lung cancer arises. And for the causes, most important cause is smoking, and the asbestos is also important cause, pollution, and there are some genetic defects which we gather through our life. Causes are unknown, but their numbers are still not crossing 30%. 70% of the lung cancers, irrespective of male or female, is smoking.
Okay, sir. So, moving forward, what are the symptoms, signs and symptoms of lung cancer, and what are the screening tests available for lung cancer?
So it is very important to know the symptoms of lung cancer, because early diagnosis is only then possible. Most commonly, lung cancer doesn't present at very early stage because the symptoms come up at a very later stage. Initially, patient comes with cough, expectoration, and sometimes along with fever. Since our country is the hub of tuberculosis, so very often other infections and tuberculosis can be confused by the treating healthcare provider, and they do x-rays at the best, and that also cannot differentiate between tuberculosis and lung cancer very commonly at the early stage. So there is a very great chance of missing, but it should be kept in mind, especially for a smoker, that these symptoms are warning symptoms: cough, expectoration, and in the later stage, weight loss, loss of appetite. All these are there, and sometimes, rarely, patient may present with metastatic symptoms, like cancer has gone from lung to the brain. So patient may come with brain metastasis, with symptoms like stroke, or come with hemoptysis coming out of blood through the cough, expectoration, or in the liver in the form of jaundice. Wherever the cancer goes, according to the organ of metastasis, the symptoms also may be there.
Oh, excellent. Sir, and what are the screening tests available, and who should be screened for lung cancer?
Actually, it is a very important question. Lung cancer, unlike cervical cancer, is not easy to diagnose by screening, because screening for cervical cancer has been approved and proven to be successful in decreasing the number of mortality related to cervical cancer. But lung cancer trial has proven that it is only effective only in case of heavy smokers, and that is the low dose CT scan, and that CT scan is not that toxic, because as you know, CT scan involves the X-rays into our body. So that radiation dosage of low dose CT scan is very low, and it can pick up very small lung cancers, and it should be done in the heavy smokers, and by clinical trial it has been proved that it helps in diagnosing early lung cancer where treatment options are better, and we can give increased life expectancy to the patients.
Okay. So, sir, coming to a very important part, which is like the diagnosis of lung cancer. As sir has already mentioned, CT scan is one of the important diagnostic tests to be done to diagnose lung cancer. And how do you stage lung cancer?
So first I will tell about the diagnosis, that low dose CT is not for diagnosis. This is a screening test. For the lung cancer diagnosis, you have to do a contrast enhanced proper CT scan. That is the normal dosage. So the radiation dosage here will be higher, and that will only diagnose that the cancer is there in the lung and it has gone into the mediastinum, because in the CT chest you will see these two only. Mediastinum means between the two lungs there is a heart and some other blood vessels and lymph nodes. If it has gone to that area, then we call it locally advanced. If it is limited to the lung, we call it local. It may be a small pulmonary nodule, we call it SPN, from where the investigation starts, which we pick up by low dose CT. But unfortunately, X-ray is not possible to diagnose lung cancer very easily at the early stage. Obviously, in the late stage, X-ray also can diagnose. Okay. And for staging, the CT scan is not only adequate, you have to study the body in totality, and with the present era, easily availability of positron emission tomography combined with CT scan. It is a hybrid test. One angle is nuclear medicine testing, that is positron emission tomography, and hybrided with CT scanner. And by that, we can precisely diagnose where all in the body. It is done from head to toe, and entire body can be screened, and you can know that lung cancer has gone to these places, and by that you can know the prognostication and the treatment paradigm of the lung cancer.
Okay. Sir, are there different types of staging, and can you tell us a bit more about the importance of...
Importance of staging is the planning the treatment, because there are basically two types of lung cancer. We call it small cell or non-small cell. Actually 15 to 20% cases are small cell. They are very aggressive disease, and their staging is very simple. Either it is limited or it is extensive. So there are only two stages for small cell lung cancer. Limited stage means it is limited to the lung or part of the mediastinum, which can be covered by a radiation port. So most important treatment for early stage small cell will be radiation. So if it is within the radiation field, so it is limited stage. And if it is gone beyond, then it is an extensive stage. Non-small cell is a bit complicated. Non-small cell have got varieties: squamous cell, adeno, large cell, and other few variants which are rare. And in these cases, there are stage 1 when it is limited to the lung. There is stage 2 limited to the one side, same side of the mediastinum, the hilar lymph node. And stage 3 will be going to the opposite side of mediastinum. And stage 4 when it is distant metastasis. This is actually stage grouping. There are T and M staging. T means tumor, N means node, M means metastasis. So according to T, there are classification 1, 2, 3, 4. There are A, B, C, D. So this is the duty of the treating doctor to precisely classify your lung cancer if you unfortunately have it, and your relatives or someone. Then the doctor will tell you precisely what is the stage. And the staging system changes, and the Society of Lung Cancer and the International Union Against Cancer, they all publish their screening, their staging system, and these are updated. So what was diagnosed to be a stage 3B around 20 years back is now stage 4, because earlier pleural effusion, formation of fluid in the pleural cavity around the lung, was earlier called 3B. Now it is considered as stage 4.
And after the patient has been diagnosed with lung cancer, so what are the treatment options available for lung cancer?
As I was mentioning, it depends on the stage. So stage is very important. At the outset, if you know the stage completely and the type of cancer, which is small cell or non-small cell, then the treatment basically depends on the histology and the stage. Most of the early stage lung cancer, stage 1 and stage 2, the treatment options are surgery. But it is a major surgery, and you have to precisely stage doing before surgery. 2 tests additionally you have to do before embarking on surgery. That is pulmonary function test, which includes the lung volumes and diffusion capacity of carbon monoxide, DLCO, and another test that is also very important, PET-CT already you are doing for everybody, but for here endoscopic evaluation of the mediastinum, because the lung cancer goes first to the mediastinum, lymph nodes, which all stations of lymph nodes are involved. That cannot be precisely told by the PET-CT always, because especially in our country, that there may be false positive by tuberculosis. So proving that lung cancer has gone to the mediastinum by EBUS, endoscopic ultrasound, endobronchial ultrasound, that is very important, and suggested along with FNSC, if you can take some tissue or cells and you can prove. But after these tests, you can go ahead with surgery. If it is little late, that is 3B, where the direct surgery is not possible, there you can have 2 options. You can start with chemotherapy, and these chemotherapies are standard chemotherapies where all trials are there. It is doublet, platinum doublet chemotherapy, followed by surgery. You reduce the size of the tumor, you reduce the low nodal involvement, and then go ahead with the surgery. But if it is not operable, or the patient has got, mostly smokers have got chronic obstructive pulmonary disease, we call it COPD, where pulmonary function test is not adequate, DLCO is not adequate, when a portion of lung is removed, and that because here you are not removing only the tumor, you are removing at least a lobe. So whether the patient can survive without that lobe, that has to be taken into account. So in such cases, though patient is technically resectable, should not be operated. So we call it resectable but not operable for his general condition or lung condition basically, or other comorbidities like heart failure and many other. In such cases, we already usually offer them concurrent chemotherapy with radiotherapy.
Okay, sir.
Every weekly we give some chemotherapy, and along with that radiotherapy for every week for 5 days, and in such way we treat them. That is up to locally advanced 3A or 3B.
Okay.
And if it has gone beyond that, when there is a metastasis, stage 4, in those cases only option is systemic treatment, because local treatment is not effective in prolonging life or prolonging, improving symptoms, because it is already stage 4, it has a poor prognosis. Earlier stage 4 diseases we used to call that they will live maximum 6 months, and chemotherapy has improved it by few months with addition of other therapies, targeted therapies. Now people are living even with stage 4 for few years.
Okay, sir. All right. So when is immunotherapy advised, and what is the difference between immunotherapy and targeted therapy? When are these therapies like advised, in what condition, of what stage of the lung?
It is actually in the stage 4 disease only. So I have elaborated about the early lung cancer treatment, that is surgery, chemotherapy, radiotherapy, and concurrent chemotherapy, radiotherapy. Now coming to the stage 4 disease, here the chemotherapy could, all types of protocols were used to chemotherapy drugs, and all drugs finally came up to a particular disease-free survival and overall survival. They all plateaued around 6 months. Majority of the patients died by 1 year. So that was the situation. Then came a breakthrough that there are some cancers which express some tumor markers like EGFR mutation. So these are the first targets which we have found in lung cancer. These EGFR targeted tablets are there. There are tyrosine kinase inhibitor, which are intracellular targets of the tablets, which called gefitinib first generation, erlotinib second generation, and osimertinib third generation. Third generations obviously are best, effective, but costly. And rest all are less costly, but these are mostly the cancers of the non-smokers who normally develop this EGFR mutation. There are varieties of mutations, and accordingly they are treated, and they do better with the targeted therapy than chemotherapy. This targeted therapy is usually used alone without chemotherapy if we find the target in the lung cancer tissue. So here the job is to do lung biopsy first, or if the other organ is involved, biopsy from that organ, and then go for the molecular testing by real-time PCR initially. Now with the availability and reduced cost of sequencing, next generation sequencing, which have a depth of coverage much better than earlier sequencing of Sanger sequencing. So now we are getting many cases of EGFR mutated lung cancer. Epidermal growth factor receptor, it is expressed on the lung cancer cells and detected by molecular testing. NGS is the ideal. And there are few rare like ALK and MET and MEC. There are also drugs, but they are very rare. And next is the immunotherapy, you asked me.
Yes.
Immunotherapy is the new entrant in the field of lung cancer. It is the self-immunity boosting medication. It is not like curcumin or like that. Immunity means you are just giving some antioxidants that which will boost your immunity. It is not non-specific immunity increasing. Here again lung cancer tissue has to be tested for expression of program death receptor or ligand in the tissue and the surrounding tissue. So we make a score, TPS, tumor positivity score, and composite positivity score. If the score is above 1%, and in some drug in 10%, some drug in there are different platforms also for this testing. It is immunohistochemistry, but each of immuno-oncology drugs like pembrolizumab, atezolizumab, they have separate platforms. So you need to guide the pathologist which immunotherapy you are trying to give it to the patient, and accordingly they will give you the result based on the immunohistochemistry expression of PD-L1 on the tumor cells and the surrounding cells. And if they are present, these drugs will act on the receptor, and T cells will mount immunity. Cancer hallmark is immune evasion. So the normal T cells do not lyse the cancer cells because of immune evasion, but if you give these drugs called pembrolizumab or nivolumab or atezolizumab, these cells will not be able to carry on with immune evasion. Now T cells will be mounting immunity. T cells are internal cell, and that is now effective, and this program PD-1 and PD-L1 action is blocked. So this T cell will act and will do cellular lysis. T cell mediated immunity will mount and cancer cell will die.
Okay, sir. Great, sir. That was a very clear and detailed explanation. And as we head towards the end of this session, so there is one last question that I would like to ask. What would you like to recommend the viewers to prevent lung cancer? What are some ways to prevent lung cancer?
That is most important. Prevention is better than cure. Yes. So first I will say that there should be awareness for this. The lung cancer day and lung cancer month is celebrated worldwide. As I have told at the outset, the smoking is the commonest cause of lung cancer. So it remains the 70% cause, and prevention of taking up the smoking habit at the childhood or adolescent by continuous education in the school level. And if at all someone is already smoking and decided to quit, so better quit it today or at the earliest. And quitting smoking is not a problem, because there are drugs which can help the blocking of nicotine receptors, and your urge for craving for smoking will be gone. And within 6 months, one can be totally craving free. But there are chances of relapse, and but there are good drugs available in India also, which can help you quit smoking.
Okay. With that message, we have come to the end of today's session. Cancer diagnosis can be overwhelming and hard to process. So the patients and their attendants are expected to have a lot of questions about the condition, about their health condition, and what lies ahead. So the purpose of this session is to educate the viewers about the treatment options available, and to help patients take well-informed treatment and life decisions. And I hope the session has been informative. And if you have any queries, you can reach out to us through Messenger and post your queries in the comment section. Thank you.